Hi, I'm Shannon Weber with Hive, a hub of positive reproductive and sexual health based at San Francisco General Hospital, and I'm here with...
I'm Dave Glidden from the Department of Epidemiology and Biostatistics at UCSF, and I'm a statistician who worked on the PrEP studies and have been involved in pre-exposure prophylaxis research for about a decade.
Great, and it is September, I don't even remember the date now, but middle September 2015, and we are here in San Francisco at UCSF, just to give a time and place to things, because this is a rapidly evolving field. And I was at International AIDS Conference in Vancouver where you gave a talk, and frankly your talk was one of my favorite talks from the whole conference, and I really think groundbreaking in the way in which you presented the data around PrEP. And you gave a summary about the pharmacology of PrEP, meaning what do we know about how the Truvada drug interacts with people's bodies. And in it, you really shifted the language. And I want to ask you about, when you were preparing for the talk, what was both challenging and exciting for you?
It's all exciting. It's an evolving field, and we now understand that PrEP works. And we've moved on from does PrEP work or not to understand more fine point questions about how does it work under certain conditions, how many doses do I need, what's the best I can do, what does it mean to skip a dose. And pharmacology provides important insights for that. So it's exciting to move from does it work to understanding a bit more about how it works under different circumstances.
Like these nuanced ways.
Exactly. And the challenging part is to provide summaries that are relevant for people's lives, because people encounter HIV in all kinds of different ways, through different parts of their body, through sexual activity, or through injection. So with all those different exposures and life experiences, it's hard to capture all the things that we know about how PrEP works and about pharmacology that's relevant for all those circumstances.
Yeah, I think one of the challenging things has been, as we try and translate what we've learned into practice and how we communicate about this language that we use, and we see oftentimes people referred to as MSM, or men who have sex with men, or heterosexual women, as if there's these two buckets of people in which PrEP might be useful for. And you never use that language in your talk. So talk to me about language and how it is that you think we might be able to do better when we're talking about HIV exposure and PrEP.
So a big moment for me is that when I was asked about the PrEP study, one activist asked me if trans men were included in the PrEP study. And this is someone who was very aware of the study, but it had not been clear until I clarified that trans men were excluded from the PrEP study. So using a term like men who have sex with men incorporates a broader population to some people than it does to others. So using that kind of shortcut actually it perpetuates misunderstandings. And yeah, if we talk about MSM and then we talk about heterosexual women, well, where do trans women include? They comprised about 13% of the PrEP population. And it's important that that be highlighted, that that was a population that was included in the PrEP study. So when we talk about language, we want to make sure that we can do it in a way that allows people to have clarity about, who we're talking about. And these kinds of shorthands, I think, are not helpful.
And so what did you end up doing? Because you were both so specific and so inclusive at the same time.
So what I did, and it's not perfect in its own way, is I talked about route of exposure to HIV. Okay, so when we talk about route of exposures to HIV, then I talked about, for instance, rectally exposed, vaginally exposed, and let's say penile exposed individuals to HIV. And then we begin disaggregating the MSM population, because they're both rectally exposed and penile exposed. And even then, heterosexual women begin to diverge because they may encounter HIV both through vaginal or through anal intercourse. So none of our studies actually captures a homogeneous group of exposure. So we have heterogeneity both in route of exposures across studies as well as identities within the studies.
So quick summary, if you don't mind, and we'll link to your talk. It's only about 10 minutes long, and again, it was one of my favorite talks. You just beautiful presentation. But give me the quick update on what do we know about drug levels?
Well, what I want to highlight before we say anything about drug levels, it's incredibly important that we understand that PrEP works, and that we know that PrEP taken consistently, PrEP taken daily, is overwhelmingly protective in broad populations of HIV exposures. It's been extremely well studied with a dozen clinical trials. So we try to answer more fine-tuned questions. And when we try to answer those more fine-tuned questions, for example, how many days do I need to take Truvada before I can expect to be protected from HIV? When we start to talk about that, we realize that the quality of the data for that rectally exposed population is so much higher. In that population, we have a sense of about how much Truvada needs to be in your system. So knowing that, we know, for instance, that taking Truvada for as little as 4 days might deliver people to protective levels. Certainly we see their protective levels by 7 days, even though Truvada is accumulating in the system for 21 days. That means that for women, because we don't have that high quality information that tells us an earlier time frame, we advise that women take Truvada for 3 to 4 weeks before expecting that they're protected. And we base it on the fact that we know Truvada works for women and that maximum concentrations in the blood are reached after 3 or 4 weeks.
So one of the things I'm hearing from you is that, in fact, some of this confusion around how PrEP might work for vaginally exposed people, be they women, and also for other populations like trans women or trans men, is because we just don't have the same quality of data, not that it doesn't work as well. Exactly.
So we happened in the PrEP study to be very fortunate to have very high quality pharmacology monitors among all those individuals infected. And that gave us pretty good guidance on a break point, the level at which we could expect protectin to kick in. Don't have quite as clear guidance.
So it's not as robust, the data there.
Exactly. It doesn't permit that kind of fine-tuning.
So one thing I realize in talking to you is how lucky we are, you know, that we're at this point that we can actually have a conversation about nuance.
Yes.
And so maybe we have that for rectally exposed individuals, but what are we still curious about? What would we still like to know in this nuance area about PrEP?
Wow. Yeah, now you're getting me going. So a couple of things. I think we would love to have higher quality information for vaginally exposed populations. And I got to say for injection populations. So in both those cases, we would really love to understand what levels are required for protection. And that's going to require doing high quality pharmacology among individuals in demonstration projects who may become infected with HIV while they're taking PrEP or who have been offered PrEP.
In this place of luxury in which we are.
I think the other thing is, what is the place of episodic PrEP in this set of choices? Many people are interested in episodic PrEP. The PrEP study delivered high quality information in a MSM rectally exposed population. And that was a population that was having sex very frequently. So when they take PrEP associated with their sexual activity, it was also pretty frequent PrEP, was pretty regular PrEP, and so people are curious about what that would mean for people who have sex less regularly. And we have no guidance about how well we might expect that might work for a vaginally exposed population. There's reasons to be skeptical. But we're curious. We'd like to know better, exactly.
And it sounds like we may learn some more information as demonstration projects, depending on what data they're collecting, publish. So we can be hopeful about that. And so, though, in the meantime, I'm wondering, you know, what do you think the key takeaway messages are? Again, kind of recapping that we're at this lucky point in which we do know that PrEP works, even if we have questions about how it might apply specifically to us. What are the key takeaways?
Well, the main takeaway that I want to make sure clear on is that pre-exposure prophylaxis is the most studied intervention in HIV prevention, with nearly a dozen clinical trials completed. We know a lot about PrEP. We know it works. We know that Truvada is gentle on the body. So any bottom line, I want it to be that people should know that PrEP works and it's extremely safe.
Yep.
That we don't need more studies to implement PrEP around the world. To date, it's only available really in the United States. And that's got to change. It's a global epidemic.
Yeah, there's huge possibility.
So whatever questions we have or things we'd like to know really pale in comparison to what we do know, which is the key thing that PrEP works.
I feel like in talking to you, if no matter who I am, considering PrEP, that there's enough information available that I could, with my provider, really weigh out my own risks and benefits and make a decision.
Exactly. It's
not like I have to wait for that next study to come out to decide if PrEP's going to work for me.
Exactly. So we're always going to be looking to fill in that picture more and more clearly, but we have the important outlines in place. And as far as the long-term effects, I want people to understand that Truvada's been used for treatment for well over a decade, and that we understand that it's very, very well tolerated by the body.
Thank you for sitting down with me and explaining this. It is very exciting, and I'm so grateful to you for the work that you put into that talk and being like humble and breaking apart everything that you didn't know and being willing to put it forward in another way. And I'm really looking forward to how we can all shift our language to be as specific as you were, but also as inclusive. I think that's an exciting next step for us too.
Great. PrEP for all.
All right.